doesn't always happen. So thank you so much. We are here to talk about considering end-of-life communication. And this is going to be a roundtable discussion encompassing collaborative perspectives of care. So actually, we're just going to take about 6 to 8 minutes per presenter, and then what we really want is conversation with you about your experiences and what you can take away from this panel so that we all walk away feeling invigorated and hopeful about end of life. So we're going to get started, and today our first presenter is Bonnie McCracken, and she is from SUNY Buffalo. Bonnie, all you.
Good morning. I'm going to focus today on the relational dialectics of end-of-life communication and end-of-life care, particularly for breaking bad news. My area of interest in this particular topic started with the veterinary perspective. That is what my research focuses on because animals' lives are one-fifth at our own. So veterinarians are consistently delivering bad news and having to deal with this end-of-life scenario. Effective provider-patient interaction, as we know, is very important. However, it is crucial during these difficult interactions of breaking bad news that healthcare providers communicate effectively. Articulating an exact definition of bad news can be quite difficult, and that it is highly subjective to one's perception of what exactly is bad. The nature of what is bad can be dependent on, or how individuals perceive what is bad is dependent on your perception of what the symptoms are, the severity of your symptoms, and what your previous knowledge is of that condition. Oncologist Robert Buckman has defined bad news as any information that has the potential to drastically alter one's perception of their future. This definition has consistently been revamped and expanded to include any information that was previously unknown that produces a negative expectation for one's future and one's present and results in cognitive, behavioral, and emotional distress. There are a variety of reasons why providers experience such a difficult time when they communicate. Oftentimes, providers are lacking in the training and skills that is required to engage in this interaction, which really does require individually tailored strategies and knowing what the patient wants, how much information they need, and oftentimes these interactions differ from what they are traditionally interacting with or what they are traditionally saying in other medical interactions. Further, breaking bad news is highly emotional. There's a lot of emotions involved. There's a lot of grief response involved. Individuals, when you hear something that's bad, oftentimes they kind of zone out, their mind goes blank. So it's a very highly emotional process, and healthcare providers have to be aware of the grief response just by hearing the bad news. Often, too, this is a difficult time for the patients and the families, so providers must be able to enhance their communication in an effort to optimize this end-of-life care. In order to do so, as researchers, we need to have an understanding of what is motivating the healthcare providers and what is motivating their way in which they communicate. These motivations we can understand from the theoretical perspective of relational dialectics theory. Basically, this theory postulates that we have competing forces or tensions when we communicate and also with our social interactions. These competing tensions are reduced to a series of polar opposites that are simultaneously experienced in a both-and fashion. In terms of breaking bad news, the polar opposites that providers often experience are openness, closedness, connection and autonomy, and certainty and uncertainty. I'll talk about each respectively. The first one, openness and closedness. The openness refers to the desire to disclose information, to open oneself up to the patient, and to engage in empathy. However, at the same time, providers have this desire to remain closed off, to be objective for the patient, and to avoid the face-threatening act of disclosing negative information. This dialectic tension also refers to the amount of information that's disclosed the desire for transparency, but also the desire to protect the patient and by not disclosing too much information that would negatively hurt them emotionally. The second tension is connectedness and autonomy. This tension is basically the simultaneous desire or need to relate to one other individual, to connect to them, however, simultaneously remaining independent. Providers want to create relationships that foster trust and care with their patients. However, becoming too emotionally involved is detrimental to the physician's health and well-being. Therefore, they have this simultaneous desire to remain autonomous, to remain detached, and to remain in control of their emotions. The last dialectic tension is certainty and uncertainty. This tension is often experienced when providers are very certain about the diagnosis, they're certain about the symptoms that the patient will experience, and they're also certain about the prognosis and how the disease is going to fall into place or how it's going to progress. However, what they are uncertain about is how long will this disease last in terms of how long will the patient be living with these symptoms, when will they need palliative care, and when are we going to be making these end-of-life decisions. These providers are consistently trying to manage these dialectic tensions, and they do that through communication and through the relationship with the patient. By managing these tensions, they are often shifting from one tension to the other, from one polar opposite to the other. Depending on which tension or which polar opposite they choose, depends on the situation. It depends on their own emotions. Are they ready to engage in a connected relationship at that day or at that moment, or are they feeling like they can't handle that particular day? It also is dependent upon the relationship with the patient and the patient's emotions and patient's perspective. Providers, though, must manage these tensions appropriately because, as we know, communication can drastically affect the patient's experience of healthcare, their quality of care, and how well they will adhere to medication and treatment recommendations. It is important for researchers to identify these contradictions within these provider-patient interactions, and identifying these relational tensions is the first step to doing so. We need to understand what is motivating healthcare providers to communicate in a certain way and how it affects their communication. By applying relational dialectics theory, this brings a unifying theoretical perspective that really illuminates the struggles that healthcare providers experience, what they confront, and how they negotiate their communication. Where to go from here? As I mentioned, my studies primarily focus on veterinarians. What I want to do is a cross-analysis of how relational dialectics theory applies to both traditional healthcare providers as well as the veterinarians, and see what we have overlapping and what may differ with these two very important yet also differing perspectives. Thank you.
Thank you, Bonnie. Tom Healy, the chair of this panel, I am not Tom, was unable to make it, so he apologizes, and I'm standing in for him, kind of moving this along as well, but I'm also the next presenter. And so for what I'm going to talk about today is part of a larger project that I've been working on for a couple of years, and I'm looking at the chaplain's role in providing spiritual care at end of life. So a couple of points that I want to talk about today indicate what communication skills interpersonally do chaplains use in providing care and how can they improve them. So in terms of the chaplain, and we're thinking end of life, so an interdisciplinary team, what is their role? And providing spiritual care sounds like a good, okay, that sounds good, but it is so ambiguous. And so part of the struggle even getting into this topic is how do we define spirituality at end of life, and what is the chaplain's actual role in doing this on the team? In doing research along the way, finding that chaplains face many challenges, including education and training, which I think overlapped with what Bonnie was saying, is that some chaplains that I talked to were very highly educated and had master's degrees, PhD, lots of training in the hospital as well, whereas some were volunteers. So when we say we're providing spiritual care, what does that mean in terms of getting them ready to do so? And then additionally the role ambiguity and working with other team members, the contrast between biomedical care and biopsychosocial spiritual care can be a root of conflict. And then additionally, when we're talking about end-of-life success, if we're thinking of outcomes and measurable outcomes in healthcare, like financially, how can we support this in a meaningful and money-saving way? Well, your patient is going to die, so what does that mean? How do we know if we're successful? So those are some of the challenges that chaplains face when providing spiritual care. And so in terms of data, transcripts from 49 chaplains, including interviews and focus groups. It was very geographically diverse sample, so chaplains from Wisconsin, Chicago, Kentucky, Ohio, DC, all across the United States. Some were face-to-face, some were on the phone, and some were via Skype. And so, again, looking at the communication during end-of-life care, and specifically in our personal communication, so chaplain and the family, chaplain and the team, and chaplain and the patient. And so three themes, three ideas that came from this are chaplains must be good listeners. They must have good listening skills, and calling that a listening presence, because their ability to absorb the information, actively listen, and then translate that into providing care for the patient. So listening to the verbal and also nonverbal cues, because at end of life we also get into mental illness, Alzheimer's, and dementia, so sometimes the patient cannot communicate what they want, so we're not hearing a verbal need, but there's an underlying concern, and so how can we provide spiritual care? Chaplains oftentimes said listening was the #1 skill that they used, and again, connecting that to the earlier comment about the education and training, it's a skill and we can learn to be effective, but if you just volunteer your time, is that you're a good listener or a bad listener in terms of communication skills? So secondly, we have the relational building. So how do we establish trust at end of life? So this relates to the chaplain's image and identity. So if a patient doesn't realize that they're at end of life and a chaplain comes into the room, patients often said, "Oh my gosh, I'm dying, please leave." Like, I don't want to deal with that. You're here because that indicates I'm dying, and ooh, we're not going to go there. So there was a barrier in terms of your image, and chaplains are associated with last rites. So how can chaplains work at building relationships and getting their foot in the door to even sit down and have a conversation with the patient, with the family members, and then additionally establishing and building trust on the team. I need to be here. I am part of this providing holistic care. Value me. So trust and identity and the relational building, so we can provide care, but also from a chaplain's perspective, trust in a higher power. Faith was a large part of this, and the chaplains themselves, to be a good chaplain, they said in their own words, is providing care for no matter what the patient wants, even if it conflicts with my own personal belief system. So trust and faith in a higher power that the chaplain is in the right place, right time, doing the right work. And then thirdly, narrative engagement. So with the communication skills of listening and relational building and trust, narrative engagement. So asking the right questions to get patients to open up and share narratives about their spirituality, about their life, and that's where the spiritual work happens, is identifying the issues that may be causing strain or tension within the family relationships, and figuring out what historical conflicts might be in families. So storytelling is a large part of this, and asking the right questions to invite people to share stories is defined as good quality care based on this study and these ideas. So In terms of implications, there are no real communication classes, or they're very, minimal for the chaplains and also doctors. If you yourself are in healthcare or you've researched this, they don't get a ton of communication skills training, yet this is part of their job, and especially on the team, working with others, if you can't communicate, that leads to conflict. So I think there really needs to be more communication classes and skills-based learning for doctors, patients, chaplains, the team. And so better use of skills helps address these challenges, and chaplain's role truly becomes that of a mediator, a facilitator, and using the skills of listening, the relationship, and building a narrative to provide the spiritual care as defined by the patient. So that's what I wanted to talk about, and So next is Lindsay Harville from James Madison University.
Hi, I'm taking kind of a different approach. My area of expertise lies in the psychological effects of death awareness. So I'm going to take, it relates to everything everyone's saying, but it's slightly different. So when we think about this end-of-life care, and that's why I really was interested to be on this panel, because I think it's really interesting thinking about psychologically kind of what goes through, whether we're at vets, which my dog just passed away, in December, so I totally understand what you're saying, or just in general dealing with either our own death or family members. Regardless, we're all thinking about our own death, and that brings up some psychological uncomfort, but also a lot of emotions. We're not really sure how to feel a lot of the time, and I think that speaks to when we push chaplains away. Like, I don't want to deal with that. For ourselves, anytime that we're coming up with wills or medical directives, or anytime you're putting that together, it forces you to contemplate your own death. What's going to happen after I die? That's not a comfortable thing to think about, and it's definitely not fun. I didn't enjoy doing it. And then when you're dealing with others who are dying, sometimes their end-of-life decisions are different from what you may want, and so that causes a conflict. Basically, it causes this dissonance, and when I started thinking about it, it's really at this evolutionary level where your desire is to live, not to die, and so it really plays with this evolutionary desire to live. So what I want to talk briefly, give you a very brief analysis of terror management theory, because it's very long and complicated, but I think I can sum it up in about a minute, so that you can at least have some kind of understanding as we go on. So terror management theory is really where the majority of my research lies, and it is a theory about the psychological effects of fearing your own death. Jeff Greenberg, Sheldon Solomon, and Tom Pozinski in 1989 first came out with their first findings, and then it's been going strong since then. It has really become quite interdisciplinary. This theory relies on Ernest Becker's ideas when he came out with the denial of death in 1973, and that argued that really this desire to live or fear of death is evolutionary. Brings up Darwin, brings up a lot, it really kind of synthesizes Darwin, Kierkegaard, all of these people over the years who have argued about this discomfort, but not really coming up with any themes. And then terror management theory puts it into a nice model. So really, when we think about our own death, we have anxiety. If you've sat and thought about your own death for a while, you eventually stop thinking about it because it's so uncomfortable. And there's 3 ways, according to the theory, that we can make this better. The first is adherence to a cultural worldview. And this is basically having some sort of core beliefs that set your reality. And such as religion or political affiliation, all that stuff makes up your reality. So whatever is your reality is your cultural worldview. And so having one, you belong somewhere. And so that makes you feel a little better about death. Second is high self-esteem, meaning not only do you have to have this cultural worldview, but you have to feel like you are a prime example of the cultural worldview, meaning that you have self-esteem, at least in the argument of this theory. So after you die, hey, it's okay, I'm dying because people are going to remember me as being a really great example of what a good person is. So that actually helps you combat with that. And then third, came out a little later than the first two, it came out in 2003, is this idea of close relationships. The more that you have, the better you feel about dying. Why? Because all these people love me, they're gonna miss me, it's gonna make me feel so much better. All right, so that's care management theory. In regards to end-of-life care, care management theory really hasn't embarked in that area. One study in 2012 came out of Johnstone, and what Johnstone did was put care management theory and this idea of cultural view together and how these differences can influence your end-of-life care. For example, the do not resuscitate request. A lot of people don't know that their loved ones have a DNR until the DNR, they're dead, right? And well, then they get angry. They get angry at the doctors. They get angry at the hospital. They get angry sometimes at their loved ones. And so this study really argues that, hey, this anger is just a cultural view clash. That's all it is. And we see this in other areas, right, with pro-life folks. Blowing up abortion clinics is a clash of worldviews. That's what this study argues, and I agree with it as well. So regardless, it all goes back to this desire to live or your fear of death. And so I was thinking about this, and I'm thinking, all right, end-of-life care, people get angry, we get that. But what role does TMT play in physician-assisted suicide? I have a blog post, or a blog that looks at kind of death and stuff. funny death stuff, if you can think that that's funny. It really is it talks about stuff that's coming out in my book on care management theory next year, so that's really the purpose of it. But I did a post about the Brittany Maynard case and physician-assisted suicide, and I was thinking, do we all know Brittany? Yeah. I was thinking, wow, her mom at first, when you look at interviews with her mom, she was really angry at first, but then she became okay. And I talked to my mom, she was like, I would never be okay with you doing that. So I'm thinking, how did she become okay? What moved her from anger to acceptance in regards to this care management theory, theoretical grounding? There's no mention, the first thing I would think was, hey, religion, right? They're going to a better place. That is a prime example of a cultural view anxiety buffer for care management theory, but they never mentioned religion, ever, in any of their interviews, in anything that her husband said, anything that she said, anything that her mom said, nothing was mentioned on religion, only that she didn't want to suffer. And so when I started thinking about this and started thinking about future research, I started thinking that part of the huge issue with our fear of death is this idea of fear of, lack of control. We know we're all dying right now. We could die when we leave this room, we could die in 30 seconds, we could die, 2 days from now, 50 years from now, who knows, right? But we don't know when, and that's really, really scary. So religion plays that role. You're like, oh, I'm gonna go when God's ready for me to go. You hear that a lot. That offers some comfort in that someone else has control of your life, so someone else is going to have control of when you go as well. But what about people like Maynard? She's choosing to die, so what role does control play in this anxiety buffer is what I'm constantly thinking about in my mind. First, is it an anxiety buffer? Taking back the control yourself, does that make you less fearful of death? I don't know, we haven't tested it in a lab yet that I know of, at least not in regards to care management theory. So that could play a role. But then two, does it work for suicide as well? I'm not sure how we ever get around the IRB talking to suicidal people, but I'm working on it. It's something that I want to do. So how can we manage often violent clashes between these end-of-life decisions and the survivors? Because it can get violent. So, and it's an evolutionary clash. So it's really kind of going against your evolutionary desires, and well, at least from the perspective of Becker. But how do we combat this? I'm not sure. Care management theory doesn't really provide any answer, but I think that it provides a mechanism to investigate in the future.
from the Center for Hospice and Palliative Care.
Hello, I'm from the research department at the Center for Hospice and Palliative Care. People better know us as Hospice Buffalo. So we work with the end-of-life population, so that's kind of our bread and butter. We see it all the time. We interact with patients and their families. And what I'm going to talk about today is more of a programmatic type of perspective as an organization, what we do to help people and their families, empower them to make end-of-life decisions so that they feel like they have control of their treatment options or their their wishes are met. And just focusing on a more national level, when you turn on the television, what do you see? Everybody talks about how the healthcare system is in crisis. We spend so much money on healthcare. In fact, there's a report in 2011 that came out saying that 5% of the population is responsible for 60% of our healthcare costs. And this 5% are people at the end of life. And it's because they're pursuing curative treatments that are aggressive and futile. And it's because they are making decisions that are less informed. If I said to you, if you had 6 months to live, you're going to die. Given the choice, would you rather live the remainder of your life with a high quality life, being able to spend time with your family, having your wishes met? I want this type of funeral. I want that when I pass away, I want to be remembered by this. Or would you rather say, okay, I'm going to try all these experimental, procedures, be in pain, not necessarily be cognitively intact because you're undergoing all these treatments? What would you choose? I personally prefer to choose something where I can spend the last few months of my life being supported by my family, spending that time, versus undergoing treatments that are very unlikely to work. So I don't know if you agree with that, but most people I talk to say, I want to spend time with my family. And so that's the whole thing about hospice and palliative care. When people hear hospice, first thing they say is, oh, it's a place you're going to die. It's a scary thing. You give up. And people don't really understand hospice. It's not communicated properly to the public. We're working really hard to do that. Hospice palliative care really is supporting the patient and their family. It's a unit of care where, as they progress towards death, that they're supported not just physically, but psychologically, spiritually, emotionally. They're facing death and dying. It's anxiety-provoking. As healthcare providers, what can we do to help them with that? And so there's programs that exist that help people transition towards that decision. And it comes down to the relationship between healthcare provider and the family. So when people are unaware what hospice really is, healthcare providers would say, well, you're giving up. It sounds terrible because then you're like, oh, I'm giving up on life. And so our goal as an organization is to communicate that when you go to hospice, it's a choice that you make. It's a choice that you make that you can still have your dignity, be taken care of, your family taken care of. And there's a lot of studies that show great health outcomes, where bereavement outcomes are a lot better for family. So for example, let me give you this. If you were chronically ill, let's say, and you're going to, and at some point in time that your disease will overtake you, and you can no longer make decisions, would you rather let your family know, okay, well, at this point, I don't want to be intubated, so tubes down you, very uncomfortable, you don't want to be resuscitated because it might break ribs, it'd be really uncomfortable. Do you want your family to know that, or do you want your family to not know and say, okay, well, clearly mom wants this, and someone says, clearly mom wants that, so your family's being put in that situation of making decisions for you that they don't know what you want. And so that makes it really hard for families. So at hospice and our palliative care programs, we have a multidisciplinary team that works with the family and say, okay, what do you want? Advanced care planning. What are your needs? What do you need to work? Sometimes there's strained family relations. they help people work through that, because with death and dying brings up all sorts of family issues here. You know, there's the son that is living abroad that feels guilty because they can't take care of their family. And so with this type of care, we ensure that the patient and the family are in a position that they are heard. It's really unfortunate that hospice is a Medicare benefit. It is the richest benefit we have offered by the US government. But only people at the end of life, very, very at the end of life, use it. Our average length of stay nationally is 19 days. The hospice benefit is offered for 6 months. And if you're diseased, if you live beyond 6 months, you get recertified and you can be in hospice for 2 years. But people go at the brink of death, and that's not what we want. You know, people that do come at the last week of life, they say, oh, hospice is so great. And yet we say, okay, well, you know, if you came in earlier, you could have had all these supportive services. You know, so that's, our goal is to be able to communicate that to the community, to healthcare providers, because when you think about it, we are a death-denying, death-defying culture. You know, we have all these medical advances, so people are trained, you know, doctors are trained to cure people, you know, doctors are great, but there is a certain point that, you know, the patient needs to decide whether or not they want to pursue that. And so the hospice benefit is such that in order to participate, you have to have a diagnosis, prognosis where you're going to die 6 months and you can't undergo curative treatment. And so by then, people are at the brink of death. And so one of the ways that we have is offering programs where you can still pursue curative treatment and still receive health care. I mean, essentially it's just good medical practice. So at this point, you're receiving curative treatment, getting chemotherapy, let's say you have cancer. But you're already thinking about, okay, I want to make sure my wishes are known. So you're already addressing all these issues. So by the time, if you do need to go to hospice, you've already made that decision. And so as a hospice organization, we have these programs that are available for people in the community. We're training healthcare providers outside of hospice to understand what it really is. And it comes down to communicating what is best for them so that they're empowered to make decisions that they want.
Next, we have Rachel Defner, who is also from the Center for Hospice and Palliative Care.
Hello, everyone. I will also be taking a psychological approach. I have a background in psychology and mental health counseling. I'll be talking about end-of-life dreams and visions, which is a big fancy word for just talking about dreams and visions at the end of life. One of the definitions that we came up with is that they're just well-documented subset of end-of-life experiences, and they can be categorized as meaningful, vivid, psychological experiences that can occur while the person is sleeping or while the individual is awake. We would call that a vision. It's not uncommon for a dream to carry over into waking life, so then we'll just kind of say that as both or a waking dream. A little bit of a disclaimer, I always kind of say this. We take the psychological approach, you know, we focus on the lived experience of the individual, you know, kind of what it means to them. We're not talking about deathbed coincidences or near-death experiences. You know, there's nothing paranormal going on here. Another characteristic of ELDVs is the sense of reality that comes with it. You know, they may wake up or come to and say, it felt so real. You know, I remember how it felt when so-and-so touched my arm. I can still feel it now. It felt so much like real life. Another thing, it's very emotion-laden, so the affect is very meaningful. You know, they can be very moved. They could wake up, you know, with tears in their eyes, be overjoyed, be extremely happy. And most of the content with the research that's been done so far, the most meaningful end-of-life dreams and visions are basically deceased loved ones, pets even, friends, you know, kind of this theme of reuniting or seeing people you hadn't seen in a while. So some of the other previous research, 88% of 66 patients that were interviewed daily in a hospice inpatient unit, 88% of them reported at least one of these end-of-life dream visions. 72% of those were the reunions with deceased loved ones, as I was saying. 17% were about living friends or relatives, and 59% were about preparing to go somewhere, or like packing or traveling. And then 28% were about past meaningful experiences. So again, this is the psychological experience. It's very much based in their reality. Another qualitative analysis on the same data found specific themes that came from the dreams. And there was the comforting presence, preparing to go, watching or engaging with the deceased, loved ones waiting, waiting to whether you leave to take them with you or just kind of, they would say they're in the room with me, they're not really interacting with me, they're just kind of waiting. I'm not sure what they're waiting for. And then unfinished business was a common theme too. Someone might ask, why are end-of-life dreams and visions such an important end-of-life experience? Throughout time, throughout culture, these kind of experiences have been reported. Today, there's been a lot more research, a lot more focus on them to figure out, kind of differentiate some of these things. It's kind of like the definition of spirituality. It's a little bit hard to put your finger on, but you can't deny that the individual that it occurs to, it's meaningful. So, my perspective is if someone finds something meaningful at the end of life, I think we should give it a second look. Another important thing is to differentiate it from more pathological changes in cognition, delirium, dementia. These are, very physical things that we can treat, attend to, but it's not uncommon for people unfamiliar with the end-of-life population to confuse these kind of waking dreams with hallucinations or with dementia, and this can lead to over-medication or to, robbing someone of a meaningful experience. So I just want to kind of paint you a little bit of a word picture how we can differentiate between an end-of-life dream and vision and delirium. So the physical state, after having an ELDV, people are usually mild, they're at rest, they're calm. A delirious person is extremely agitated, moving all around, very agitated. They might be picking at their clothes, picking at their IV. It's a very distressing experience. Their cognitive state, it's been noted that with ELDVs, there's actually heightened recall and acuity, so they can remember those little details, that sense of realism. And these are people who maybe, have been pretty forgetful. It's not uncommon as you decline towards death to become a little bit more forgetful. But they can recall the dreams the next day, the next week, it really sticks with them. A delirious person, extremely disorganized, very confused, difficult to connect. Relationally, I've seen people when they discuss their ELDVs, they go from withdrawn and kind of introverted to sharing a story, connecting with people. They kind of come out of their shell a little bit. And a delirious person is just extremely withdrawn, disconnected, and there's an inattention, that inability to connect because of the delirium. Again, the emotional state, they're comforted, they're calm after having an ELDV. Delirium, they're extremely distressed. And it's also very distressing on the family or caregiver to see, their loved one having a delirious episode. Spiritual state, they're often peaceful, transcendent, especially with the ELDVs about the deceased loved ones. So they're saying, I know my husband's waiting for me, or I know my sister was there, and she always took care of me as a child, so I know she's waiting for me. And that just helps them kind of make sense of their world. And a delirious person just can't even get to the realm of spirituality because their basic needs are just not being met. They're just so disconnected with the spiritual realm. So currently my research focus, the last 2 years I've been doing a longitudinal study. I went and met weekly with people at the end of life, kind of going home to home, nursing home to nursing home, talking about their dream experience, talking about their vision experience. I also measured existential well-being through a scale. I also looked into sleep quality because there's been a link between fragmented sleep and the emergence of delirium. So we really wanted to control, to say, okay, this is definitely a dream. This is definitely delirium. because that's a big clinical issue right now, to be able to differentiate between the two. And we haven't finished the analyses yet, but I have a ton of anecdotal information I would love to share with you guys. The number one thing I noticed just clinically going into a home, you know, it might be chaotic, it might be people already actively grieving. Just the simple act of saying, oh, don't worry, like other people have dreams like this. Because I was like, oh, my dreams are crazy. I can't tell you my dreams. You'll think I'm crazy. There's this fear of ridicule, this fear of, you know, we're just gonna lock you up because you're crazy. And I said, no, most of the people I talk to have very similar dreams, and the relief on their face. Even the caregivers will say, oh, Mom was saying she saw Dad. I thought she was crazy. So validating that experience is just, it reconnects them to the world in a way that is so unique. Another interesting thing, we can talk more on this. I'm sorry, I get so into it. Thank you.
And finally, we have Jen Breyer, Center for Hospice and Palliative Care.
Hi, good morning. As a member of the team of the research department at the Center for Hospice and Palliative Care, I'm one person who's striving to assist and help to improve the quality of life for patients and families through development and design of research projects, also in a psychosocial nature. And specifically, we've designed a variety of psychosocial studies that aim to improve patients and families' sense of dignity, self-worth, feelings of value, comfort. And furthermore, we find great value in the lived experiences of our patients and caregivers. So one of the studies I'm going to talk to you about today that I'm personally working on is how we can learn from the dying. And it's a qualitative study of the wisdom of hospice patients. And before I get into that, though, I just want to take a quick straw poll. How many of you have someone in your life who you would consider wise? Or how many of you think you are wise? I should see every hand in this. So, thinking to yourself, what makes that person wise to you? And I won't ask you to share that, but just internally, what causes you to be drawn to that person or seek counsel or advice from that individual? That's kind of what geared this project. We find value in the lived experience of our hospice patients and what they've gone through. And we feel that not only is it important, but that it's something that's worth sharing to others, to caregivers, to clinicians, to the community, people outside of the hospice setting as well, which is why part of the reason that we're here as well. Just kind of getting the word out. And I think Pay and Rachel did a nice job of summarizing some of the things that we do. But one of the studies that we worked on with respect to wisdom of hospice patients is we interviewed qualitatively 15 individuals in the hospice population. And these are terminally ill adults undergoing hospice care who were nominated by clinicians, so they were referred to us as people who seemed especially wise. And we based our definition of wisdom on research and literature, and our perspective is that of a positive psychology base. So I'm not sure if people in this room are familiar with that, but ideally it's this notion of this perfect utopian integration of knowledge, character, mind, and virtue. And it's different from other human strengths in that it facilitates an integrative or holistic approach, right? So towards life's challenges, problems, and in that we're looking at past, present, and future. How have patients handled challenges in the past? How are they handling them currently? What goals or advice do they have for, or plans do they have for future plans of attack? A second aspect of wisdom is that from this positive psychology base is that the individual and collective experiences are tied together. Okay, so one can't exist without the other. What that means is wisdom is time-tested knowledge that guides individuals, groups, and society. Okay, so right now we're currently qualitatively analyzing these 15 interviews, so we're in the middle of analysis currently. And we're using a CQR method, which is consensual qualitative analysis. So basically it's Kay, Rachel, and myself in a room together where we come to the table with our own personal biases, lived experiences. We have an understanding of each other's perspectives, right? And we're trying to look at the data, looking at these audio recorded transcriptions to see if we can find a collective truth towards what we're looking at, all right? So, but this, you know, with a positive strengths-based approach to studying this marginalized population, you know, I think we found some pretty interesting things so far. I would like to just talk about some different themes that we've seen throughout these 15 interviews. And one is this, there's a great deal of personal meaning, obviously, if you're talking to people about their perspective, their lived experience. So there was a lot of how we make sense of the world around us came through in a lot of interviews, as well as, not surprisingly, facing of illness and death. Right? As their lived experiences being terminally ill, some of these issues and concerns have come to the surface through those interviews as well. Personal growth, not from illness or death. So we've had patients just share their experience where they have this realization of, I was here at point A, and through my lived experience, I've now come to point B, and I've realized that I've grown in, you know, this way or that way. I've now adapted, learned, and gathered more skills and tools to be better prepared to handle my future challenges or my current challenges. Advice. I think one thing that Rachel and Peg might agree with is that when you are interviewing or you're sitting with these patients, a lot of them are of an older generation. Now, that's not to say that you have to be old to be wise. All right, I've interviewed patients who are in their 40s. I think it has a great deal, wisdom has a great deal to do with, you know, your lived experience and the challenges and struggles that you face and you go through. So, but I also found that patients are very willing and open to share their experiences and share their share their perspectives in the hopes of, you know, helping people. So one of the questions we ask is, what advice do you have for someone who is in your current situation or similar, is sharing similar experience, and they may offer their advice that way. What experience do you have, or what advice do you have for someone who is much younger, someone who is, not that we're guaranteed tomorrow, but someone who may have many years left to live, and we've you know, sought their advice in that way. We also asked participants to define wisdom for themselves. What do you think is wisdom, or what makes a wise person? Seeking out multiple perspectives in that realm. And I would just like to leave you with a couple of quotes. One of the questions we ask is, what is the meaning of life? Pretty abstract question, right? Pretty broad, escaping, or what's the meaning of your life, to narrow it down. And one such response is probably just the importance of every single day. The importance that people see every single day for what it is, that it is such a gift, and it's taken so for granted by so many. That for me, it's just an appreciation of every moment. And the best part of life is life itself. Living it well and being thankful for what you have and being surrounded by people that you love. So that's just one example of what I do at Center for Hospice and Palliative Care and how important it is to really be able to listen and communicate with those individuals in this capacity. So that's what I have.
And what I'd like to do now is open it up for questions that you might have, so we can have some collaborative discussion.
Are you having much success in communicating bad news into the curriculum of medical schools and residency programs? I know that I'm a full-time hospice and palliative physician, and that's one of our most requested CEUs, and I do that a lot. My son's in medical school, and they're beyond when I went, where they didn't talk about it at all, in that they had scenarios that they were taped to see how well they presented bad news to their patients, but they had no training on how to do it before the scenario. I sent him the presentation. he loved it. He did really well. He said, can I give this to my class of 206? And I said, no. So, because I can't, you can't broadcast the presentation from my organization. But anyway, but they don't really teach it in general. And so how do we get that more into the curriculums?
Right. So what I'm doing right now, and this is particularly for my doctoral dissertation, is I am doing qualitative analysis of the ways in which particularly veterinarians are breaking bad news. And what I'm aiming to do is identify strategies that they're using. What I want to do with those strategies is come up with a framework that providers and veterinarians can use, and that way we can implement that. There are a couple strategies or protocols that are already in place, such as Buckman's Spikes model.
Right.
Yep, and there's a communication strategy called Comfort model as well. But these are slow to implement, and medical curriculum and the veterinary curriculum, they're slow to utilize these. And I'm still finding it, whether it be with veterinarians who deal with breaking bad news and end of life on a daily, multiple times a day basis, but also with the healthcare providers. Even recent grads are still not as prepared as they really should be. So I'm not in the position yet to say, here's exactly what we're going to do to change this, but I'm most certainly trying to identify a way to break into that, so that way in a couple of years we can change the way that these medical students are being taught, so they can be prepared, because ultimately it's going to be better for them, and it's going to be better for the patients if they are proficient at this difficult task. So I'm on my way.
Just to follow that up, I think at the undergrad level, even for all students, like teaching a health communication course and covering why it's important in healthcare to consider communication. That way when they walk away, they are aware that they can ask their doctor for more information. They become more of a patient advocate. So I, working very hard in my health comm classes to empower them to know that these are options. And we do spend, a couple weeks on medical school curriculum and training and showing them, videos of what it's like. And I think at the undergrad level, even if you don't become a doctor, awareness of healthcare helps them be able to ask the right questions once they do leave. So I think it is hard to hook up with a medical school curriculums, but I think CEUs are a great way. And if we can get more people to offer those sorts of credits, maybe that's a really good way to do so.
Yeah, and going back off of what you said too, it might be advantageous to approach these students at the undergrad level, because the pre-medical students or the pre-veterinary students, we might be able to reach them, whereas the med school and the veterinary schools, their curriculum is very tight-packed, and administrators or the department chairs, the deans might argue we don't have time for this, so they might fit it into one class. It might be an hour within a class. So maybe if we approach these students earlier and get them thinking about it sooner, then we can start changing the curriculum that way.
That's a good idea, because that's when my son asked me. He says, I hear you doing this all the time. What did you learn? So I sent him the protocols and all of that, because he heard it all growing up. So yeah, when they're in pre-med, they eat up everything you give them, because they think they have to. So that's a good place to get them.
Well, in our research department, we have volunteers, student undergrad volunteers, and a lot of them are pre-med, and a lot of them come in and say, okay, I just want experience with patients, give me whatever. But I think seeing that some of them have been with us for such a long time, they've really grown, and they've even said to me that when they go to medical school, they may or may not pursue palliative medicine, but they have a whole new perspective of how, conversation should be had. Patients always talk to them and say, when you become a doctor, remember this, that we are individuals, we're humans, we're not just a disease. And so I think just different opportunities for students to be exposed to the end-of-life population, I think, is another avenue that we can train up future health providers in that sense.
That's a good idea.
I can just jump in. A lot of medical schools are having a lot of are expressing interest in medical improv as a way of teaching, and I think it's SUNY Stony Brook that has a program that Alan Alda developed, but The Feinberg School of Medicine at Northwestern also has a program, and their assessments have shown most of all that there's a spike in physician confidence. So when med students do this, they feel more confident. And part of that has to do with the fact that the improv situation is set up so that medical students are not only the providers, but also the patients. So that has been, I mean, it's really great in terms of teaching active listening. And it's a lot of times something that a med school will say, okay, well, we can do this. The other thing that we hooked up with at the University of South Dakota and the Sanford School of Medicine is right there, was with the Med School Simulation Center. So that has, you know, lots and lots and lots of really great ways to teach personally, but also quickly. So that has been it's been a real spike. I'm still interested. I would love to be able to say, okay, I'm going to create, I'm turning this into a question. I'm going to create a class called Breaking Bad News. Tell me what you would put in that class.
Actually, so I have taught an end-of-life class, and part of that was the delivery of bad news. I think it's really hard to mentally prepare students for that course, and we all talked about like the emotional burden. So we're trying to use movies more. 50-50 is a great scene of Breaking Bad News, and having the students analyze that is a wonderful way where you don't even have to be the one standing up there saying how important it is. They can see it and be like, oh my gosh, like this, you know, that's horrible. And they see it, they apply it, and then they know it, and then you can jump into different conversations. So I think inserting film to help springboard that has been really beneficial.
I would also consider, just from a counseling perspective, incorporating some type of self-care or mindfulness into that, because like Kelly mentioned, it is really deep, serious stuff that we're talking about, and it's something that we're all going to face one day, and especially with the young, bright-eyed, bushy-tailed undergrads, you know, they might not consider that because they think, oh, that's so far off in the distance. Maybe they haven't even thought about it. So I would definitely want to prepare them in some way, you know, practice basic mindfulness, something as simple as, you know, controlled breathing, or mindful eating, could be body scan, quick little things that can bring them back to the present moment and, you know, make sure that they're well balanced in that aspect.
I would add in how to manage the grief response, because when an individual receives bad news, they immediately go into shock. 50-50 is a wonderful example of what happens to a receiver when they hear bad news. In the film, the main character, he kind of zones out, and his hearing is muffled. It kind of has that Peanuts, the adult or the teachers, the way that they communicate. That's what happens. As soon as a receiver hears that bad news, their mind goes blank, they start the grieving process. If the communicator is not aware of that grief response, they're not going to be prepared. And what happens are these providers are delivering the bad news, and they're throwing it at this patient. You have stage 4 metastatic lung cancer, and you have 4 to 6 months to live. And they're going to continue talking, and that patient is not going to hear them. So what needs to happen is these providers need to stop, check in with them, ask for recall, then take another step and deliver a little bit more information. Stop again, ask for recall, and manage the grief response the entire time. Having an awareness of exactly what an individual experiences during that time is going to alter that experience dramatically. A lot of times with these receivers, with these individuals or the patients, they'll leave that office. They may not even remember the conversation to begin with. They don't have. So when they go see that for a checkup or go see that provider again, they'll say, "What do you mean? You didn't tell me this." Yes, we did, but the provider doesn't. There isn't a direct connection between the provider, because they remember the conversation, but the patient doesn't. So we need to draw a bridge and connect those two. I think grief response and social support is the best way to do that.
I think too, to kind of piggyback off that, tolerance of silence. If you're giving bad news or you're trying to be with someone in their grief response, you're protecting yourself from thinking about your own mortality. So immediately we want to fix it. We want to, make them not feel the way they're feeling. And that can come through as just saying a bunch of things really quickly to get out of that situation. So building a tolerance to just sitting silently and being present is very difficult, especially in today's society, I feel like, where everything's so instant and everything's about distraction. So being able to hold that uncomfortable feeling, which is easier said than done, but I would add that to the class.
Along those lines, and I don't know if maybe this is why the people fresh out of medical school are having issues with they're confronting their own mortality, but research actually says that people who are younger have more death anxiety than people who are older, and so I'm not sure if that's it, but maybe, and I know that, I mean, I didn't go to medical school, I'm the other kind of doctor, but I don't know how much personal information you can give, but I think just in regards to messaging design, it might help if the doctor somehow pulls out some, kind of personal experience with it. Yes, it involves them confronting their own mortality, but maybe somehow, there's no training them to be okay with their own mortality. Is that, that's evolutionary, right? We want to live. Yeah, but maybe, if they had, somewhere to help them know that they're not alone, that might help just know that, okay, this is my old cultural view, this is my new cultural view, I have cancer now, but look at all these other people who have it with me, and I can talk to them, and, we see that with online support groups and even in-person support groups, so.
I was wondering, does tribal affiliation or culture, I guess maybe you could call it, have to do with end-of-life vision and the way people do respond?
Yeah, well, definitely. Some people, the number one thing is openness to it. So, recall a gentleman who told me such a meaningful dream that was clearly about his wife who had passed from breast cancer. She was coming to him, giving him this beautiful message, and at the end I said, what was that like for you? How did that make you feel? And he's like, it's just a dumb dream. Clearly, he was just not ready to work on that. And some dreams do require more exploration. But we did have, I think, out of the sample of 83 people, I think there was only 1 or 2 individuals who were Native Americans. And they were a lot more likely to call it a vision than a dream. Whereas some of our, Christian brothers and sisters preferred to say it was just a dream. Even though I was awake, it was a dream. So basically it's just finding the language that they're comfortable with. You hear visions, you think hallucinations, or, there's something weird going on. Dreams, I feel like, are getting a little bit more acceptable, even if we're not ready to tack on that meaning to them yet. Does that answer your question?
Yeah, there's a lot of rubbing shoulders more intimately with cultures, particularly with immigration people from all over the world. And in my classes, some of my students' intercultural communication classes, students share about things about end-of-life death visions and coming-of-age experiences in parts of Africa, let's say. And as we, as become more intimately involved here with these diverse cultures, it must be what you're talking about, a bridge in terms of.
Oh yeah, and I really do take that developmental perspective. Like, I think it's just a natural part of that stage of life. So whether it's coming of age, visions or dreams, whether it's end of life ones, they're meaningful experiences that are just helping the individual wrap their head around what is happening to them. They're just making sense of their world that has been, shaken by crisis or is coming to an end. It's really just helping them make sense and find comfort in that.
So, I'm sorry, I just want to kind of clarify that dreams or visions are more like a subconscious thing that is brought up for the person to help them cope, like a way of them subconsciously helping them cope with that, or like what exactly brings that on?
I would love to have a microscope that I could just, look inside them, but I personally don't really think the ideology of, who's giving these dreams to them, or are they self-directed, are they unconscious, are they subconscious? I think the important part is just when they remember them and when they're spontaneously meaningful. So, there's tons of ways you can do dream work, exploration of dream work, but it's the end-of-life dreams and visions that are innately meaningful and instantly comforting.
And somebody can have more than one of these experiences
Yeah.
throughout their process of their life.
The people I saw weekly, like a couple women really got into it, they recorded their dreams, they would have like 7 to 8 dreams a week. And some would, like one gentleman I saw for a year, he only had one, and it was right at the very end.
I think what's interesting too, and Rachel had touched on constraints earlier, but is the nature of the dreams and how they change over time too, is something that's pretty, I don't know. If you
Yeah.
know.
So we found a transitional sequence. So imminently dying individuals tend to dream of these deceased loved ones, waiting, watching, comforting presence. People, when I first started seeing them, right as they enrolled in hospice, they were much more dreaming about living friends and relatives, unfinished business, sort of almost stressful dreams. And then there's this transition period in between where they're suddenly nobody else in the dream, just them. And they're usually wandering in a place that is meaningful to them. We had an architect engineer who's wandering in a beautiful white building, an avid kayaker who's suddenly on this really windy river and couldn't see where the drop-off left. And none of them said they were frightening, which I thought was interesting, because to me that sounds frightening. They said, I'm just curious, I don't know what's next. So it's pretty interesting.
I think one of the things we didn't get a chance to mention is one of our other research projects. So a lot of times those are imminently dying, these dreams are very comforting for them. But there's a small percentage of individuals that have distressing visions. And one of our other research projects explore using these dreams that they have and doing meaning-centered dream therapy. So going through the dream with them and, for lack of a better word, interpreting their dream, seeing what this dream means to them and how they can draw meaning from that and resolve, whatever issues they may have. So one example that we have is this one individual. She would have this recurring dream where she would walk down this paved road, and then there's a red house to the right, and then the paved road goes straight, and then the dirt road goes off somewhere. Pretty classic, what you would think, as an outsider, you're thinking, okay, she's dying, so she's there's a fork in the road. But she herself did not know why she was having this dream. She just kept having it. And so the research therapist that we had on our team explored it with her. Okay, when you see this dream, what are the major images in the dream? What do they mean to you? So it's all completely driven by the client. So the client said, okay, this paved road to me means certainty, life. This is something she came up with herself. The therapist does not, do anything with that. The paved road means death, uncertainty. And then the research therapist asked, what does this red house mean to you? What does the house mean? She's like, well, it's a source, red means strong. And she eventually came to the conclusion that that was her family. She was, the rock in her family. She couldn't go down the dirt path. She said she knew she needed to, but she couldn't. And what it was she didn't want to leave her kids. She's this 9-year-old woman, so her kids are in their 60s now, but she's like, they're my children, I can't leave them, I don't want to leave them. And she said, I wish I could have a different ending to this dream. And so the research therapist said, we can do it. So what he did was guided imagery. So he had her close her eyes and said, okay, you're at this road, what are you doing now? She's like, I'm walking towards the house. The house, she said, had no windows, no doors. She said that, she's like, going through this exercise, she said, I'm going to the back. Oh, there's a door there. I open the door, it's my family. And so she went through this sequence where she decided that, her family was let out of the house, and she was able to walk down the dirt path with her family behind her. And by the end of that session, she was in tears, and she essentially was able to move past that so that she can go on to, to the next stage of her life, which is death. And And she stopped having that recurring tree after that therapy session. And so that's one of our other research projects, is using these dreams that these individuals are having, and helping them through, working through any issues that they may be having.
So considering, time constraints and things like that, if you don't have the availability to do this kind of dream therapy, do you think that just, talking through these dreams with them is beneficial and helps them find meaning and things like that?
Yeah, so just even being, whether it's clinical caregivers, family, just being open, like just by asking, oh, did you have any dreams this week? I saw a person who was maybe laying in bed, maybe half asleep, maybe not connected, go, I did have a dream. You know what I mean? And they're like, I didn't know I could share that, or that anyone was interested in hearing that. And it takes, 30 seconds to ask about a dream. And you don't need to analyze it or interpret it, just share that experience, People who are bedridden or people who have physical issues where they literally can't go out and live their lives in the world, they're still going to be living their lives psychologically. So having that meaningful connection is just, it makes a world of difference.
And not only that, but allowing them to understand that it's a normal experience. Helping to normalize that experience, I think, is so important, and educating them in the fact that, this is not something that's happening to only you. This is something that's commonly occurred. And I think that it's important to educate at all levels, because so many times we see, even within hospice, is that we're very quick to want to medicate. Oh, they're having dream and vision, so being able to differentiate between, and obviously there are some, there's differentiation that needs to happen between dream and vision and a hallucination that's a delirious patient. So it's important to, for clinicians to be educated, for caregivers to be educated, so that they know, and for patients to be educated too, so that they can understand and accept that, okay, this is, it's normal, it's okay. I'm not, like Rachel said, I'm not crazy.
So for anyone who's interested, we do have YouTube videos that we give you a link to of our patients who were willing to share their dreams. So that can be used as educational material for your, for your hospice. So what, when people say, oh, people having these dreams or visions, they might be so out of it. But when you see these videos, these people are very alert, very, very cognitively intact. And so people are very surprised because they have this image in their head of like, oh, they're totally out of it. No, these are people that are very, present. And so that is often very surprising for people who are unfamiliar with these end-of-life dreams and visions. So if anyone is interested, we can send YouTube links to that.
So we have time for about one more question. Is any other? Any comments from panel or thoughts? I always feel like after these sessions, we should just write a book. Just write a book. Okay, well, thank you guys so much. Appreciate all comments and feedback, and have a good conference.